Welcome and thank you for joining us for today's webinar, Healthcare-Associated Legionnaires' Disease, Current Strategies for Response and Prevention. My name is Kathleen Amos and I work at the Public Health Foundation, and I'm joined by my colleague Vanessa Lammers, and we are pleased to be hosting this webinar on behalf of the National Center for Immunization and Respiratory Diseases at the Center for Disease Control and Prevention, or CDC. We have a fantastic webinar planned for today and I'm very much looking forward to sharing it with you. As started, we would like to just go over a few housekeeping items for this webinar. So on the slide, you should see an image of the attendee control panel, which you should also have on the right side of your computer screen. And this control panel is your hub for interacting with the webinar. So first, in that control panel, you should see an audio section. You have two options for accessing audio for this webinar. You can either listen through your computer speakers or call in over the phone. If you're using your computer speakers, please choose the computer audio option. If you're using your phone, please choose the phone call option and enter your audio PIN, which can also be found in the audio panel. And please just make sure to select the audio option you're choosing to use. And if you do listen over the phone, be sure to also mute your computer speakers, so that'll help reduce any echoing or background. Regardless of which option you choose, all webinar attendees are muted. The slides for today's presentation are available for download in the handout section of your control panel. The links that are included in the slides are not live during the webinar presentation itself, but they are live in that handout. So if you'd like to have those, if you download that copy of the slides, you can use those to go to the additional resources. And throughout the webinar, please submit your questions or comments for the presenters via the questions box in your control panel. Please feel free to send in your questions at any time, and we will address as many as possible during the Q&A session at the end of the webinar. If you have any difficulty with any of the technology for the webinar, please also just use the questions box to send us a message, and we can help you troubleshoot. And finally, we wanted to let you know that this webinar is being recorded and the archive will be available following the webinar. Did you know the incidence of reported U.S. Legionnaires' disease cases grew by nearly 9 times from 2000 to 2018? Nearly 10,000 cases were reported to CDC in 2018, the most cases ever reported. However, even this high number is likely an underestimate since many cases do not get recognized or diagnosed. Since more cases of Legionnaires' disease are typically reported in the summer months, now is the time to make sure you have the latest information on diagnosing and preventing this disease, which is fatal for about 10% of those who get it. Clinicians, healthcare facility leadership, public health officials, and building owners can all play a role in protecting people from Legionnaires' disease caused by Legionella bacteria. Clinicians are in a unique position to make sure cases are detected, allowing rapid investigation by public health officials and prevention of cases. For this webinar, we're joined by Chris Edens, Legionella epidemiologist in the Respiratory Diseases branch within CDC's National Center for Immunization and Respiratory Diseases, who will provide an overview of Legionnaires' disease in the United States and steps that can be taken to identify cases, collect needed specimens, and reduce the risk for Legionella exposure through water management programs. Dr. Edens received his doctorate in biomedical engineering from the Georgia Institute of Technology and his undergraduate degree in the same field from the University of Texas at Austin. Following his postdoctoral studies at Georgia Tech, he joined the CDC's Epidemic Intelligence Service and was assigned to the Division of Healthcare Quality Promotion, where he primarily investigated outbreaks of healthcare-associated disease. He joined the Legionella team in 2016 and currently focuses on outbreak response and studies to better understand the burden of Legionnaires' disease in the United States. We're very pleased to have him today. Welcome, Dr. Edens. And before we dive into the content of the webinar, we do have 3 quick polls to help us get to know a little bit about you in the audience today as well. So I'm going to turn it over now to Vanessa to take us through those.
Great. Thanks so much, Kathleen. Welcome, everyone. We're going to do the first poll, which is, what type of setting do you primarily work in? Clinic or medical office, hospital, long-term care facility, public health organization, or state and local health department? And you vote in your GoToWebinar control panel under polls. So we'll just give everyone a second to find that. Excellent. Thank you, everyone. I'm going to give everyone just one more minute. So poll is in the GoToWebinar control panel, the dashboard that has the chat box and the handouts, and you vote directly on there. All right, I'm going to go ahead and close this poll and share the results so we can see what kind of audience we have. So it looks like we're over 30% of public health organization, and then also a lot of folks from hospital and state or local health department. Great, and then the next poll is, what is your profession? So we'll launch that poll. The options are physician, nurse practitioner or physician assistant, nurse, infection control or facility administrator. And again, the poll for GoToWebinar is in your GoToWebinar control panel. Great, we'll just give everyone one more minute. I'm going to close that poll and share the results. So we have largely nurses and infection control professionals. And we just have one more poll. So if you weren't able to vote in the first two, the third poll and final poll is, have you heard about CDC's Legionella Water Management Program Toolkit? Yes, no, or not sure. And again, the poll is on the GoToWebinar control panel. Excellent. I'll just give everyone just one more second to vote. Thank you all for your participation. It's great to see who we have in the audience. And we're going to close that poll and share the results. So kind of an even mix of folks who have and have not heard of that. Great. All right, now we'll pass it all over to our presenter. Take it away.
Thank you. Can everybody hear me? I had to swap headphones really quick. My phone dropped the call.
Yep, we got it. You sound perfect.
Great. So I don't see the slides up yet. I still see the results of the poll.
Oh, no problem.
There we go.
Do you see yours? Perfect.
Yes, I see the disclosures page, and then I guess give me control so I can advance the slides.
Yep, you should have it now. Does that work?
Perfect. Yes, it did. Good afternoon, everybody. Thank you for joining this webinar. Hopefully I'll teach you a little bit about Legionnaire's disease, or if most of you have already heard about Legionnaire's disease, then maybe this will just be a great refresher as we enter what we at CDC refer to as Legionella season, as the water heats up both outside of facilities and inside of facilities. This is typically where we see the greatest increase in our number of cases. So first, nothing to disclose, and the stock disclosure of the findings and conclusions of this presentation are those of myself and do not necessarily represent the views of the Centers for Disease Control and Prevention or the Agency for Toxic Substances and Disease Registry. So today I have a few objectives that I want to make sure I cover, and then I also want to make sure I leave plenty of time for question and answer. First, talk a little bit about what Legionnaire's disease is and describe trends in the United States over the last 5, 10, 15, 20 years. Identify the risk factors for Legionnaire's disease and how to test for this condition. Understand proper specimen collection and how it can relate to case surveillance and outbreak response. And then finally, identify the elements of a comprehensive water management program to prevent Legionnaire's disease from occurring in the first place. So Legionella, the causative agent of Legionnaire's disease, is a gram-negative bacillus. It's an intracellular parasite found commonly in free-living protozoa in fresh water. There's more than 60 species of Legionella that have been identified throughout the world. though Legionella pneumophila accounts for about 90% of reported U.S. cases each year. That's not necessarily true worldwide, but in the United States, Legionella pneumophila is the species that we consider the primary causative agent of Legionnaire's disease. So as was mentioned in the introduction, Legionnaire's disease is on the rise in the United States. In 2018, which is the last year we have complete data for, we identified 9,933 cases of disease in the United States. That represented a pretty stark increase in cases, not only compared to time periods further in the past, but also compared to time periods just over the last few years. We get the question a lot of why the number of cases has been increasing so rapidly, and we think that it's almost certainly multifactorial. It could have something to do with anything from more knowledge of Legionnaire's disease among diagnosing physicians, which results in more appropriate testing being conducted. It could have something to do with temperatures warming across the United States. So periods where the water is warm enough to sustain the bacteria cover a larger percentage of the calendar. It could be the aging both population of the United States, putting more people within the risk strata, and the aging building infrastructure, as I'll talk about in a minute. The age and quality of the building infrastructure can really contribute to potential exposure to Legionella bacteria. But for probably all of those reasons and more that we haven't identified yet, cases continue to increase year over year. It was also mentioned at the top and by myself about the seasonality of Legionnaire's disease. So you can see here some data from 2016 and 2017 that show a pretty marked increase in the summer months and late summer months compared to the cooler months at the beginning of and ends of the year. Depending on the exact weather patterns we see across the United States, the seasonality can be more or less pronounced, as you can see on this graph. But we typically start to see an increase in reported cases in early June, leading into August and then September. And the lateness of the Legionella season is really defined by what weather is looking like in the United States, especially in kind of the Northeast, where a large burden of the Legionnaire's disease in the United States is located. So how do you actually get Legionnaire's disease from Legionella? So I mentioned at the start of this presentation that Legionella is a pretty ubiquitous organism. It's found in many different freshwater locations. Basically every stagnant pond or lake of fresh water, if you look hard enough, you can probably find Legionella bacteria. But generally the bacteria in those environments is not at a high enough concentration to cause human disease. So when that bacteria increases in quantity and enters a premise plumbing system is typically where we see the risk of actually acquiring Legionnaire's disease start to increase. Legionella, we found, grows best in large, complex water systems that are not adequately maintained. This could include a hospital. This could include a large building, possibly with a cooling tower style device on the roof. And as you can imagine, this can also include entities such as cruise ships, which have incredibly complex water systems. Once the water has entered the building and procreated enough to cause a risk of human disease, you still have to be exposed to the bacteria to get sick. We typically see exposures to Legionella bacteria occur through a few different devices. I'll talk a little bit about these more specifically in a few slides, but faucets, hot tubs, cooling towers, anything that can aerosolize water, which is then inhaled by the patient, can pose a risk for dissemination of Legionella bacteria. Once susceptible people inhale that bacteria, if they're in the risk strata, they have a higher chance of becoming infected and developing Legionnaire's disease. So I've mentioned Legionnaire's disease a lot so far, and I will in the future as well, but I do want to distinguish that there are actually two distinct clinical conditions caused by Legionella bacteria. The first, and arguably the more well-known, is Legionnaire's disease. So this is identified primarily by an acute onset of lower respiratory illness with fever and or cough. There's additional symptoms that may be present, but those are generally the diagnosing criteria. It is almost always co-located with pneumonia, either clinical or radiographic. We believe that this is a true infection. Replication of the organism occurs within the patient's body, and that organism can generally be isolated through either generally a lower respiratory specimen specimen or sputum sample. The incubation period is commonly 2 to 14 days, though the kind of peak of that bell curve generally occurs between 5 and 6 days. The attack rate is pretty low for kind of unknown reasons. Even in situations where you have a pretty high dose of bacteria, only about 5% of those exposed develop full-blown illness. Treatment is antibiotics. A number of first-line antibiotics are very effective against Legionnaire's disease. Isolation of the organism I mentioned is possible. Hospitalization is very common, partly as a result of the way data is generally identified. Almost all cases of Legionnaire's disease reported in the United States are among patients who were hospitalized. And as mentioned previously, the case fatality rate is about 10%. Pontiac fever is basically the inverse of all of these different conditions. So the condition itself is milder and self-limiting. It does not present with pneumonia. It is traditionally described as a flu-like presentation. There is no pneumonia, as I mentioned. The thought is that this is actually possibly an inflammatory response because it is not possible to isolate the organism from a patient suffering from Pontiac fever. The incubation period is much shorter, between 24 and 72 hours. It's generally an extremely acute onset of symptoms. The attack rate is very high in situations where you have an outbreak of Pontiac fever. Almost all of those exposed develop some level of symptomology. The treatment is purely supportive. Antibiotics do not limit the duration of illness. Isolation of the organism has not been documented, and the hospitalization rate is extremely low. So why do we talk about Legionnaire's disease in conjunction with healthcare facilities? So between 2000 and 2014, CDC investigated a number of different outbreaks of Legionnaire's disease across a number of different locations with different factors and different numbers of cases and commonalities. And we analyzed that for a publication. You'll see the citation down at the bottom of the slide that was published in 2016, looking at commonalities between these different outbreaks. And what we found was about a quarter of all the outbreaks that CDC investigated were in either a long-term care facility or a hospital. And among those outbreaks, a majority of them had some association with a shower or a faucet, which is a type of aerosolizing device, which is quite commonly present in healthcare facilities and long-term care facilities. In addition to clusters typically being associated with these kinds of large buildings, the cases that are identified with healthcare also have a slightly higher rate of fatality and negative consequences. The reason for that is probably because a patient who was already in a healthcare facility prior to exposure to Legionella often has a number of comorbidities that might make them at risk for more severe illness. But regardless of the reason, we find that cases with a healthcare exposure have a higher percentage of death than cases that are not associated with a healthcare facility. Oh, there it is. So you can see the case fatality rate at the top. While the percentage of cases associated with healthcare is relatively low, only about 18 to 20%, the case fatality rate of patients associated with healthcare is much higher than associated with other modalities such as travel or assisted living or senior living. So the risk factors for Legionnaire's disease include patients over the age of 50, smoking, that's either current or historical association with smoking, any kind of chronic lung disease, emphysema, COPD, immune system disorders, systemic malignancies, and a number of different underlying illnesses. Diabetes is one that a recent study found was a really strong co-predictor of Legionnaire's disease severity, but that also includes other diseases such as renal failure or hepatic failure. So we get the question a lot in the context of healthcare facilities of who should be tested for Legionnaire's disease. So generally, adults with pneumonia who are immunocompromised require intensive care because we generally see Legionnaire's disease as a particularly specific and severe pneumonia. They may have healthcare associated pneumonia, so that's always a trigger for potential testing for Legionnaire's disease if they acquired the pneumonia following admission to the hospital. If they have failed outpatient antibiotic therapy for community-acquired pneumonia, so I mentioned that a number of frontline antibiotics are very effective against Legionella bacteria, but not all of them. So if a first-line antibiotic has failed, it's possible it's because it's an antibiotic that does not have coverage for Legionella. And then also if the patient has reported travel away from their home within the 2 weeks before symptom onset. We found that travel is an extremely strong predictor of whether or not a patient has Legionnaire's disease. And I will note that we recommend that in a setting of an outbreak associated with a healthcare facility that has already been identified, we recommend that all adults with pneumonia in that kind of a setting be tested for Legionnaire's disease to ensure that all cases are identified. So the primary diagnostic for Legionnaire's disease is the urinary antigen test. Legionella is also culturable, and we recommend that both a urine antigen test and a specimen for culture are collected from patients that are suspected to have Legionnaire's disease. While the UAT is rapid, it only detects Legionella pneumophilus serogroup 1, which is the most common cause of the disease, but it's certainly not the only causative organism for Legionnaire's disease in the United States. Additionally, culture allows for the detection of all species and serogroups, and most importantly, with regards to an outbreak investigation, it allows for a comparison between clinical and environmental samples to help determine the root cause and potential location of the bacteria that is infecting patients in an outbreak setting. So for surveillance purposes, we define healthcare exposures in two different ways, and these are a little bit different than what you might have seen coming out of CDC over the last couple of years. We recently conducted an update of the CSTE position statement for Legionnaire's disease, and as part of those discussions, we worked with our state and local partners to kind of better define healthcare and healthcare exposures. These surveillance definitions can be found in the appendix of the CSTE position statement with a little bit more information about the background for why they was determined as such. But currently, CDC defines a presumptive healthcare-associated case as a case with greater than or equal to 10 days of continuous stay at a healthcare facility during the 2 weeks before onset of symptoms. This was previously known as a definite healthcare-associated case with a little tweaking to the language. And then a possible healthcare-associated case is defined as a patient that spent a portion of the 14 days before date of symptom onset in one or more healthcare facilities. So given those surveillance definitions, the CDC's recommendation is that a full investigation for the source of Legionella bacteria should occur when a single presumptive case of a healthcare-associated Legionnaire's disease is identified in a facility at any time, or greater than or equal to 2 cases of possible healthcare-associated Legionnaire's disease within 12 months of each other at the same facility. So these definitions are pretty broad and pretty sensitive, but we believe that's warranted given not only the risk of large outbreaks occurring in healthcare facilities, but also the higher rate of death among patients who acquire their disease within a healthcare facility. So what does it mean to conduct a full investigation? And then before a full investigation is conducted, what can be done to reduce the risk of ongoing Legionella transmission right now, once cases have been identified? So I'll click through a few of these as I speak, and I won't say all of them, but in general, they all have the same theme. And that theme is try to avoid having patients and susceptible individuals contact water that may be contaminated with Legionella bacteria. So that includes avoiding therapy pools and spas. That includes avoiding water coming from faucets and showers that has not been filtered. That includes looking at ice machines and ensuring that ice machines are using a filter or they are discontinued until the source of the bacteria is identified. And for transplant patients, we do recommend using sterile water for any kind of water-based activity like toothbrushing or drinking, or flushing feeding tubes due to the increased level of susceptibility among patients with those kinds of immunocompromising conditions. But the general gist of all of the immediate control measures is how can we prevent the Legionella that may be in the water supply from contacting patients and getting them sick. So once you've implemented your immediate control measures, what does a full investigation entail? So once again, I won't necessarily read everything on the slide, but it falls into a few different categories. The first is trying to get a sense of all of the cases that are potentially associated. This can be done using a line list of possible and presumptive cases. This can be done using a retrospective review of cases that have previously been associated with the facility, or suspicious pneumonias or a suspicious increase in pneumonias that may not have been tested for Legionella, but may indicate a problem outside of the cases that have been definitively diagnosed. And then considering water restrictions, as I mentioned previously, and or the implementation of point-of-use filters. I do want to call special attention to development of a risk communication plan. A lot of times when healthcare facilities have cases of Legionnaires' disease, once they are reported in the press, there's typically questions asked of those facilities. So we really recommend trying to get ahead of that and really thinking smartly and thinking going forward about how to have that kind of a discussion and how to answer questions associated with healthcare-associated disease. So once you've done kind of the pre-work, which is trying to get a handle on how many cases you might have, then comes the environmental assessment piece of a full investigation. That is a really in-depth look at your water system, how water moves through your building, where water could potentially impact patients, where control measures might have been violated, be that the temperature of the water, be that biocides that are included in the water that comes in from the city or from wherever the water is sourced. It's really trying to get a sense of where patients may have been exposed. And so that's really useful for two purposes. One, to help identify where water restrictions might need to be implemented. And second, to determine where environmental sampling might need to occur. So healthcare facilities are generally large, complex buildings or clusters of buildings. It's not feasible to sample every single faucet in every single room or every single shower in a facility. The environmental assessment can really help narrow down where sampling might need to occur to ensure that that sampling event has the potential to fully explain the water system while not overwhelming both the samplers or the folks that are actually doing the testing. All of this can help you determine how long you need to conduct active clinical surveillance and if environmental sampling needs to be continued going forward, and if any kind of follow-up remediation or changes to the water system need to occur. So I've talked so far about what Legionnaires' disease is and also how to identify cases and how to identify outbreaks and what to do when you have an outbreak. Now I want to talk about the third piece of Legionnaires' disease that we work on at CDC, which is prevention. What can a facility do to proactively ensure that they are not identifying cases and are not identifying outbreaks of disease? So in 2017, we published an MMWR looking specifically at healthcare-associated Legionnaires' disease, and we found that Legionnaires' disease definitely associated with a healthcare facility. So these are cases that have a very, very high likelihood that the patient acquired it from the healthcare facility. We found that that's deadly for 25% of people who get it. So you can see that that number is quite a bit higher, both above the overall number of the case fatality rate and the case fatality rate of patients with any kind of healthcare exposure. So acquiring the disease in the healthcare facility is more deadly and appears in the data at least to be more deadly than patients who acquire it outside of a healthcare facility. Legionnaires' disease prevention and response requires a multidisciplinary approach. And the real highlight of this particular article was that we found that almost all of the problems that led to healthcare-associated outbreaks could have been prevented with more effective water management. And so a lot of folks who work in healthcare facilities may be more generally aware of Legionnaires' disease prior to 2017, but a lot of facilities, Legionnaires' disease kind of popped up on their radar with the CMS memo requiring acute care facilities and skilled nursing facilities and critical access hospitals to develop a water management program to prevent the risk of Legionella growth and spread within healthcare facilities. This was not a requirement prior to 2017, but after 2017 and the update in 2018, we've seen anecdotally in our data a really huge increase in interest among water management, among healthcare facilities, among these types of facilities. And we've also seen a large uptake in the number of facilities implementing these plans. I believe in 2018, some questions around water management were added to the National Healthcare Safety Network module to allow CDC and states to better capture how those plans are being implemented and what those plans look like. We're still doing some work to analyze that data, but anecdotally, I can say that we have seen an increase in these plans, which is really great to see. So what do I talk about when I mean water management programs? So water management in the context of Legionella was really kind of pushed into the public sphere with the publication of the ASHRAE 188 guidance. So this is the risk management for building water systems standard, published in 2015, I believe. It's been updated marginally a few times since then. It's really a step-by-step guide to creating a water management program, and to help facilities implement these kinds of programs. CDC created what we call our water management toolkit. So that kind of translates the more engineering language in the ASHRAE 188 standard to something that can be understood by anybody, from facility owners, facility operators, maintenance staff, engineering staff, even infection prevention and control staff. We really believe this toolkit is made for anybody who is interested in developing a plan to prevent Legionnaire's disease and prevent Legionella from growing and spreading in their building environment. I do also want to note that ASHRAE Guideline 12, 2020 was recently completed and published. This is a long time coming. It replaces a document that was previously published in 2000, and it includes some of the more practical implementation ideas of, how to develop these water management programs, how many control points should you be looking at. It has some more information on potential testing for Legionella bacteria. We haven't quite implemented this plan into our water management toolkit, but that is something that we plan to do going forward. But I did just want to mention that, there are more documents from the ASHRAE organization out there besides simply the ASHRAE 188 standard. So with the last section of my presentation, I'm going to talk at kind of a pretty high level of, what are the steps to developing a water management program? And then at each step, what are some things you need to be looking for? What are some things you need to be thinking about as you walk through the 7 steps that are included in our toolkit? Just to read them off to start, the first is establishing a water management program team. The second, describing your building system. 3, identifying areas where Legionella could grow. 4, deciding how to mitigate those areas and what kind of measuring you're going to do to ensure that growth can't happen without you knowing it. 5, establishing limits that, when breached, result in a defined series of actions. 6, making sure your plan is running as you expect. And then finally, documenting and communicating all activities to all members of the team. So first, establishing the team. I won't go through everything on this slide, but I will mention, so I've said a few times about the multidisciplinary nature of water management, especially water management in healthcare facilities. When developing one of these teams, you really need to concentrate on ensuring that you have buy-in from all the different levels that might impact your ability to successfully prevent Legionella from growing. That means having folks from management that can make decisions and make changes if need be, having folks from engineering and building maintenance that understand the building system and can properly explain questions and determine issues and figure out ways that certain issues could be remedied if control limits are breached. And finally, especially for healthcare facilities, having folks from the infection prevention and control team is also extremely helpful to ensure that if the plan needs to be tailored, if there's certain parts of the facility that have different kinds of patient acuity levels, that have different kinds of risk factors among patients, that the plan can be tailored to those environments as well. The second, describing the building water system. So this kind of trips up a lot of folks because I know from personal experience, having been on site in a lot of healthcare facilities, large hospitals are complex. They have buildings that were built at all different times with different types of water systems, with different types of piping, and then a wing is demolished and rebuilt as something different. And so the complexity can get really daunting when it comes to a healthcare facility's building water system. But I do want to say that this is extremely important. I can tell you from personal experience that I have been on site at healthcare facilities where there have been large outbreaks of Legionnaire's disease. And the first question we always ask when we're helping state and local health departments conduct these investigations is, how does water move through your building? You have this many cases on this floor in this wing of the facility. Where does that water come from? How does it come in through the main? Where is it heated? Where does it flow after that? Is it on a circulation loop? All of these types of questions are really required to conduct a true full environmental assessment And it's also helpful for the epidemiology perspective as well, that if you see that it's a particular riser or a particular leg of the water system where the cases are occurring, that can really help target the response. So describing this water system, it doesn't have to be fabulously complex. It just really needs to get at a high level of where does the water come into the building, what happens to it after it comes in, where does it go, and where does it end up? And just ensuring that that is complete and that it is updated when updates to the water system occur, be that a new wing or be that changing to the existing structure. If you have a really nice water system layout that is obsolete, that doesn't do anybody too much good. So using that plan, identifying where the risk of Legionella growth is, that could be water heaters, that could be sinks and showers, that could be decorative fountains or cooling towers, just making sure that you know where Legionella might grow, and if it does grow, where are people going to get potentially exposed. And once you've identified those areas where risk exists, identifying control points, how you're going to monitor them, and most importantly, what you're going to do if you exceed those control points. So these control points could be anything from disinfectant levels at points of use. It could be the water heater temperature. It could be the temperature of the return within the water line. There's a lot of different ways you can look at your water system and a lot of different locations where you can put a control point and where you can be regularly monitoring to ensure that your water is within the parameters that can prevent Legionella growth and spread. But as a lot of these things, they all depend on having that descriptive of your water system and having those people on your water management program and water management team that can answer these questions, help design this, and if changes need to be made, ensure those changes are made. So I mentioned the control points and making sure you're monitoring them. I won't go through these examples. These are included in the water management program toolkit, which the link is on this slide. I encourage everybody to download. But one really important thing is you can't have these control limits and then not do thinking about what you should do if they're not met. If you don't write down what's supposed to happen, a lot of times it just turns into a big discussion and solutions don't get implemented and changes don't get made. So it is really important that once you've identified control limits, identified maybe a temperature range where the water needs to be maintained to prevent Legionella growth, you have something written down in your plan about what to do if it's not in that range. That if, you know, at the 5th floor of your building, the temperature coming out of the hot water faucet just isn't quite hot enough, knowing that maybe you need to go back and change the temperature on your water heater, or maybe there is a balancing issue and something needs to be changed within the piping. So the 6th thing is making sure your program is running as designed. Another bit of anecdotal evidence from myself is that I have certainly seen healthcare facilities with really robust water management programs that aren't using their data. So they're collecting, you know, weekly temperature monitoring from hundreds of different control points throughout the healthcare facility, and there's a case. So the first thing we're going to ask is, what are your temperatures looking like over time? Have there been times when the temperature coming out of the faucet is not within your control limit? And is that consistent? Is there ups? Is there downs? What does it look like over time? So ensuring that all of the data that's collected as part of a properly functioning water management program is adequately used. It doesn't do a lot of good to be collecting numbers, writing them down on a sheet, and then putting them in a drawer that nobody can look at. It really needs to be part of the water management team and part of the water management program to track that data over time, identify areas that might have persistently low chlorine or persistently low biocide, identify areas where temperatures just aren't quite as high as you want them to be, and really have that inform the decision-making and inform program review. We like to talk about water management programs as kind of a living document, that it doesn't do a lot of good to write it down, you know, bind it up, and then put it on a shelf somewhere. This really needs to be kind of an ongoing discussion with both the water management team and the folks implementing the water management program itself. And then finally, documenting and communicating all activities. If there's issues that need to be brought up to the building owner operator, making sure those issues are documented, making sure those issues are backed by data, that the analysis is robust, and that any changes that need to be made can be made, and that any changes that need to be made are communicated up to the personnel who have the authority to do those changes, and then clear instructive guidance is given down to the folks who will actually be implementing those changes. We've certainly seen scenarios where a big change was made to the water system, and that information just didn't make its way all the way back up to the water management team. And so, control points that might needed to have been changed weren't changed. And so the program was no longer truly monitoring the entire system. It was only monitoring part of the system, which allowed for a situation where Legionella could grow and spread and subsequently resulted in infected patients. So just ensuring that all of this information, all of this documentation, all of these data are not siloed away, that the information is communicated and is used in an actionable manner to prevent disease from happening and prevent the conditions for the growth of Legionella from happening. So we have tons of response and prevention tools on our website, the vital signs I mentioned, the water management program toolkit, but we also have documents to help develop a laboratory response plan. We have environmental assessment forms. We have sampling procedure and protocol documents, in addition to some YouTube videos of how to do sampling of various parts of a water system. All those are available on our website, which is cdc.gov/Legionella. So I really would encourage you to go to that site. It feels like every month we're putting another piece of material on that site or clarifying some of our guidance. It really is a living document, and we really try to make it useful for all factors of public health, from state and local health departments to healthcare facilities that are actually investigating and identifying cases and clusters of Legionnaire's disease. So in conclusion, Legionnaire's disease is on the rise in the United States. About a fifth of Legionnaire's disease cases reported exposure to a healthcare facility in the 2015 survey. Definite or presumptive healthcare-associated Legionnaire's disease is deadly for about 25% of people who get it. It's important to encourage clinicians to order proper tests, which we recommend as both the urinary antigen test and a lower respiratory specimen culture for patients with severe pneumonia or healthcare-associated pneumonia. Legionnaire's disease prevention and response requires a multidisciplinary team, especially in healthcare facilities, and implementing a water management program is really critical for controlling disease, both within healthcare and within other types of buildings and environments with complex water systems as well. So that's all I have for today, and I think the last slide is Q&A. Yep.
Yes, thank you so much, Chris. This has been fascinating. We are getting questions coming into the questions box. We do have about, looks like 10 minutes or so Q&A, so do continue to send your questions or comments in through the questions box, and we will start addressing them now. So we have a number of questions, Chris, that relate to Legionella and the growth of Legionella. And if you covered any of these already, maybe you can just elaborate a little bit or remind people. But one question is, how long does water need to sit before there's a concern of Legionella growth, i.e. a building isn't used for a week, a month, longer than that?
That's a really great question, and is particularly timely in this day and age, and as the result of the coronavirus pandemic. There are buildings out there, typically not healthcare facilities, but lots of buildings out there that have been sitting dormant and have not had water moving through them for a prolonged period of time due to stay-at-home orders and other types of shutdowns. We don't have a lot of data on how quickly Legionella can proliferate, but we know just from the experience that we've had in outbreak settings, it can be pretty fast. Legionella, once it enters an environment with, a rich source of food, such as iron or, a biofilm in a pipe, and the right water temperatures, so, that 85 to kind of 117, 120 degree that we consider kind of the ideal growth range for Legionella, it can spike pretty quickly. And that's one of the real reasons why we really encourage water management programs to be, robust and also timely, that those types of measurements, those types of control point measurements are conducted pretty frequently to ensure that if there is a situation where the water might get into the growth range, that can be remedied pretty quickly. I do want to plug, I didn't include it in this presentation because it's kind of put together before the whole COVID thing happened. There is some guidance that's linked to straight from the first Legionella website page on CDC's site, talking about reopening considerations. So building reopening considerations surrounding kind of the coronavirus pandemic. So I really do encourage you to take a peek at that. It does have some things to think about as buildings and devices are kind of brought back online after a shutdown. And I believe a lot of those recommendations and a lot of those bits of guidance are pretty broadly applicable for any scenario where you have a building that may have stagnant water. Thank you.
Fantastic. I think I'm just scrolling through the questions now. I think you answered several of them in that answer. We had questions about the temperature that's optimal for the growth of Legionella, as well as, do you see, and I don't know if there's anything more you want to say to this, but do you see the potential for the increase in cases due to pandemic shutdown of some businesses? We're just talking about who should businesses contact when reopening? Is there anyone in particular, or, refer to that guidance that you just mentioned?
Yeah, that's a great question. With regards to what we think cases are going to look like, I think there's a lot of competing factors here. It's very, very preliminary data, but we have seen a pretty sharp decrease in the number of reported cases in 2020 as compared to this time in 2019. Our guess is that might not necessarily be a true decrease in cases, but maybe a decrease in testing, just because, as a lot of folks in healthcare know, Legionnaires' disease is not the number one thing people are worried about right now. We do have some worries that all these stagnant buildings and all this stagnant water, once the summer months hit, could result in kind of a bolus of cases. In addition, we have some, anecdotal stories from the folks who've been on Legionnaires' disease much longer than myself, that back in the H1N1 pandemic in 2009, facilities and doctors, both in inpatient and outpatient clinics, once the outbreak had been going for a little while, it became very important to fully diagnose potential cases of pneumonia with their causative agents, which actually resulted in an increase in testing and an increase in cases. So it's something we're certainly worried about. With regards to who to contact, if you are already working with a consultant or a third-party group to develop a water management program and to manage water in your building, they would, I think, be a great resource. Additionally, your state and local health department could probably help as well if there are specific questions about how to reopen while maintaining, safety for patients and maintaining safety for guests. And as I mentioned before, we have some stuff on our website. I know there's lots of resources out there that are kind of targeting this reopening metric. We don't really endorse or not endorse any of those specifically, but there are documents out there, both from us and from other public health entities. Oftentimes, the state and local health departments have some guidance for this as well, but I think they would be a great resource too. Thank you.
Perfect. That's helpful. And just, I guess maybe a clarifying question. When we're talking about healthcare facilities, does that include the water lines of?
I'm sorry, can you repeat that again? Does that include?
Oh, someone just asked if that also includes dental offices.
Dental offices are an interesting case. There's water, and that water is associated with patients and, is often associated very closely with patients, their mouths and where they're breathing. So I think the risk is certainly there. I know some dental facilities are more stringently regulated with what the water needs to look like in those facilities, so that tends to help. But one complicating factor is that a lot of dental offices occur in buildings not owned by the practice. So, retail dentistry often occurs in, a large commercial complex where one specific segment of it might be the dentist's office. And in those cases, we really encourage dental practices to reach out to their building owner operator to ensure that water is being properly maintained in those buildings. We do kind of track how dental associations occur over time. It's not a huge it's not a huge exposure source, but the cases certainly do occur. And I think in the literature, there are some evidence of clusters associated with dental clinics as well. So I think the risk is there. And, facilities just need to be cognizant of that risk and making sure that they're aware of the steps that are being taken by their, facility owners and operators to prevent that kind of growth and spread.
Perfect, thank you. We also have questions about sort of assessment or response. One specific question, how detailed does the building water system schematic that you were talking about need to be?
It's a great question. And I think it really depends on the facility and the kind of exposures that are potentially present at a facility. You know, an office building where the exposure may only be, you know, the sinks in the bathroom, probably poses a lower risk than a transplant center or a rehabilitation area of a facility that has a lot of tubs or a lot of, you know, misted water, jetted water, and stuff like that. Our recommendation is it should be detailed enough that if patients on a particular wing were to get sick, you can pretty easily, using that documentation, get a sense of where that water is coming from. A lot of healthcare facilities have a number of different boilers or water heaters or possibly water storage locations. And, you know, which boiler or which water heater, water that potentially infected a patient came from, is really important, both epidemiologically and how to fix the problem. So we really recommend that it needs to be, you know, specific enough so that you can kind of track the water through the facility, and also so you can get really a full sense of where those risk factors are. If you know there are no showers on a particular wing, then you know that showers aren't something you have to worry about there, but maybe there are showers somewhere else. So it's tough to get too much more specific than that, but you want it to be specific enough that it will give you the information you want if cases are identified or a cluster is identified. Thank you.
Perfect. We also have a question about testing and whether random testing in hospitals is required, or if not, will it be?
Do you know if that question is related to environmental testing or patient testing? I'm guessing it's the former.
There's no further information on that, so.
So I'll speak to the former. Okay. Testing for Legionella bacteria in the absence of cases is a decision that should be made by the facility in coordination with their water management team. Currently, neither CDC nor the CMS memo I described earlier explicitly recommends for or against testing in the absence of cases. ASHRAE 188, the document that the water management toolkit produced by CDC is based on, lists testing as one potential way to verify the efficacy of your water management program. As I mentioned before, there's a little bit more language around testing in the recently released ASHRAE Guideline 12 document. We're really still, it literally just came out right in the middle of the coronavirus pandemic. So we're at CDC still kind of digesting that and figuring out how that's going to plug into what our guidance currently looks like. But at a national level, we don't recommend for or against. It's certainly one tool in a toolbox. And if testing is performed, we encourage facilities to think hard about how that integrates into their water management program and what they are going to do if they find a positive. What you don't want is to conduct testing, find a positive, and then not know what your next step's going to be. I will say specifically, that's at the national level. Some state and local jurisdictions do require testing. So whether or not testing is required may very well depend on where your healthcare facility is. I know, for example, New York State, I believe, has more stringent recommendations or more stringent requirements on testing in healthcare facilities than other locations. So the answer to that question may very well be location specific as well.
Excellent, good to know. We have a couple questions also about filters and the point of use filter. Do you have any recommendations related to that?
That's a great question as well. We get that question a lot. So at CDC, we're not able to recommend specific models or brands. We can't endorse anything at that level of specificity. The language that we use is the filter should be 0.2 micron or smaller pore size microbiological filter. That can encompass a range of different filter companies and filter styles, but the kind of pore size is, the really important constricting factor, that you need a pore of less than 0.2 microns, and then you need to be really sure of the manufacturer's recommended use for the particular filter you buy, and that really should help inform what kind of filter that you're purchasing, because different types of filters can last for different amounts of time. There's filters that need to be replaced every 30 days. There's some that can go out to every 60 days. I think there might even be some new ones that can go out longer than that. But ensuring that whatever filter you choose to use during this kind of an outbreak is tracked pretty closely to make sure it's not exceeding its recommended shelf life. And also, especially if you're in kind of the midst of an acute outbreak where there's maybe a high burden of Legionella in the water, you can end up with fouling. So these filters might clog, and that can result in, failure of the filter. And also, in certain situations, it can result in just the patient taking the filter off if they're not getting water, for example, in a shower or something like that, like in a long-term care facility. So we really recommend that any facility that's looking to implement filters as part of water restrictions really look into the types of filters they're buying and make sure that those filters kind of correspond to their individual need, and also that once they're installed, they're being properly maintained so that they can be most efficacious.
Perfect. Thank you so much. And thank you all for joining us. I want to be conscious of everyone's time. I know we're about a minute away from the top of the hour. We would like to just say thank you all once again. Apologies for not getting to all of the questions that have been submitted. There's some fantastic questions that have come in today, and we're excited that we got to discuss as many as we did. So we'd just like to thank you for joining us for this webinar. We hope you enjoyed it. As we mentioned at the beginning, we have recorded the webinar, and the archive will be available soon on the Public Health Foundation's website. A link to that archive will be emailed to you as soon as it's available. And you'll also be able to access the archive from www.phf.org/immunization once it is posted. In addition, from that page, you'll be able to access the slides from the webinar today, as well as the archives of previous webinars. So we'll leave today's webinar open for the next few minutes. Please do continue to share with us any questions or comments that you might have through the questions box, or reach out to us following the webinar at immunization@phf.org. Thank you so much, and thank you, Dr. Eden. And we hope you all have a great rest of your day. Thank you.
Thank you very much, everybody.